Hello, this is Annette Rebel, and today's podcast will be about a keyword review for 2019 in the topic area hepatology and gastrointestinal. So, as the interning exam is really about repetition, again, please keep in mind a lot of these keywords are redundant and repeated from last year. So here's the list from 2018. And for completeness, please review my podcast for last year. I will focus in today's podcast about those new or emphasized keywords for this year. So we'll focus on the liver, big surprise, it's me and the liver, hepatic blood supply, hepatic function, function assessment, a little bit liver transplant, and then the differential diagnosis for postoperative hyperbilirubinemia. In the GI system, new is the review of the CARCINOID syndrome and enhanced recovery protocols. And then we'll look at liposuction and laparoscopy physiological changes. So let's start with the liver. The liver is a very important organ, not only for metabolism, but also for synthesis of a lot of proteins our body relies on. It weighs about 1.2 to 1.5 kilos, and it does receive a lot of blood supply. About 20 to 25% of your cardiac output go through the liver per minute, representing about 1.5 liters of blood flow per minute. And two blood vessels provide blood flow to the liver: the hepatic artery, which derives from the celiac artery in most cases, sometimes also for the SMA. And the other blood vessel providing blood to the liver is the portal vein. Here, the nutrient-rich blood draining from the almost entire GI system brings blood flow and nutrients substrate to the liver. The distribution is about 1/3 comes from the hepatic artery, 1/3 of the hepatic blood flow, and 2/3 of the hepatic blood flow come from the portal vein. So while there's more blood coming from the portal vein, the oxygen delivery, however, is about like 50-50. In this graph here in the slide, it shows you the organization of every liver lobule. In the corners, you have the triad of a branch of the portal vein, branch of the hepatic artery, and bile duct. All those 5 corners, and then as blood flows from the portal vein and the hepatic artery to the middle, that's where the drainage system is. The hepatic veins return the hepatic blood to systemic circulation. It's also called the central vein. And obviously the oxygen supply and substrate supply is higher in the corner, and as more and more you go to the middle, that decreases. Anatomically speaking, there's a very short distance from the hepatic veins. Right and left hepatic veins join very closely to the diaphragm, then enter the chest, and so therefore very close are to the right atrium. The hepatic vein pressure, therefore, is very affected by your right heart function or dysfunction. In CVP actually represents very closely the pressure in your hepatic veins. Due to closeness, also high influence of the intrathoracic pressure on the hepatic vein pressure and the hepatic vein flow. So how is the hepatic blood flow regulated? Obviously, there's a very strong intrinsic blood flow control, meaning the hepatic metabolism affects the local hepatic blood flow distribution. Since the portal vein really doesn't measure the composition of venous blood composition. The intrinsic regulation more applies to the hepatic artery flow. Not only intrinsic control, but also there's extrinsic controlling factors on the hepatic blood flow. The hepatic artery buffer system we review in one of the other slides. The metabolic regulation on the hepatic blood flow means if the portal vein is acidotic, oxygen poor, and rich on CO2, that stimulates the hepatic artery blood flow, so therefore this increases. The hepatic circulation also has an adrenergic receptor control with alpha and beta receptors. It also affects probably here more the arterial side of circulation. Dopamine does not have any effect on the hepatic blood flow, but glucagon does. Glucagon causes arterial dilation of the hepatic blood vessels. That's why we use octreotide actually, because octreotide inhibits the glucagon effect. So in portal hypertension or GI bleed related to hepatic dysfunction, octreotide will reduce your portal vein blood flow and therefore decrease the bleeding. The other medication commonly used affecting hepatic blood flow is vasopressin. Vasopressin is more geared towards splanchnic vasoconstriction, so therefore decreasing your hepatic blood flow and portal vein blood flow. One of the key words in 2018 and also now 2019 emphasized is the hepatic artery buffer response. So since we have two blood vessels bringing blood to the liver, the question is like, how do they interact with each other? The portal vein blood flow fluctuates depending on how close I am to my last meal. So if it's very nutrient-rich blood, the portal vein blood flow goes up. If I'm fasting, the portal vein blood flow goes down. To maintain a constant oxygen and blood delivery to the liver, the hepatic artery will compensate for those fluctuations in the portal vein. There's obviously a limit to how much the hepatic artery can compensate. The maximum response for 50% decrease in portal vein flow, the hepatic artery can compensate. The current theory about mechanism is that adenosine secreted in the liver cyanoids is responsible for that response by causing hepatic arterial dilation and therefore increasing the hepatic artery blood flow. Now, since we know that the hepatic artery compensates for fluctuations in portal vein flow, question is like, does this work both ways? Answer to that question is like, no. If you have changes in hepatic artery blood flow, as it would be systemic hypotension or isolated decreases in hepatic artery blood flow, the portal vein does not compensate for that. So after circulation of liver review, now let's talk about liver function. Here in this little graph, it shows you what all functions the liver is involved in, and obviously there are plenty. We touched earlier on the anatomic organization of liver tissue, but here to repeat, at the corners of the liver lobule, there are hepatic artery branches, portal vein branches, and a branch of the bile duct. As more and more you go into the middle, meaning the drainage system, the central vein, as more and more your concentration of oxygen and substrate decreases. So therefore, metabolic functions are organized in those zones. The periportal zone, zone 1, there you have oxygen, you have substrate. So a lot of those metabolic functions like gluconeogenesis, and glycogenesis, beta oxidation, P450 dependent functions are organized or located in zone 1. The metabolic functions which don't really need that much oxygen are located in zone 3, as it would be for ketogenesis, glucuronidation, or lipogenesis. So how do we assess the function of the liver? And the keyword here was more about synthetic hepatic functions, but I broadened it up a little bit because obviously we have more liver function tests. Some of the liver function tests focus on the hepatocellular damage, the hepatocyte necrosis, and this would be your AST and ALT. Both those enzymes have different time frames when they are elevated or when they start to rise. But AST and ALT really only show you if there's tissue loss and hepatocyte damage. Other liver function tests focus on cholestasis. That would be your alkaline phosphatase or your gamma GT, because they are released when there is stress on your bile conduction system. The ALP, while it's highly dependent on liver and bone function, but also the other tissues, placenta, kidney, who when breakdown may release. The gamma GT is a very sensitive parameter, very early on involved if there is an abnormality in your bile conduction, but it's not very specific, unfortunately, and it's elevated commonly in alcohol-related liver dysfunction. So narrowing down, when we want to look at the synthetic liver function assessment, we need to look at what the liver actually produces. Albumin is the only side of, albumin is only synthesized in the liver. So therefore albumin is a good parameter of liver function, has a very long half-life, up to 20 days, but it's not only the albumin synthesis, it's also a lot of other circumstances which will affect your albumin level, as it would be nutrition, critical illness, protein losses, as it would be through the kidney or GI system, in your hormonal balance. The thyroid function and adrenal gland function also affect your albumin level. So yes, it's only produced by the liver, but there are a lot of diseases which may affect and cause hypoalbuminemia. The liver is a major production site for coagulation factors. All coagulation factors except factor 8 are produced in the liver. And it also produces your anti-thrombogenic factors, as it would be protein S and protein C. So coagulation cascade surely gives you an indication for liver dysfunction. And then there's also bilirubin. While bilirubin is a product of the hemoglobin degradation, it is processed by the liver to make it into a form which can be excreted, the conjugated bilirubin. And we will look at a differential diagnosis for hyperbilirubinemia later on. Also, don't ignore the platelet count. Thrombocytopenia can be an indication of increased resistance through the liver tissue, as it would be liver fibrosis, and an indicator of portal hypertension. So overall, to summarize that, how do we assess liver function after liver surgery, hepatectomy, or liver transplant? Look at the synthetic function by coagulation factors. An INR elevation after hepatectomy most of the times indicates liver function compromise. Check bilirubin and bile production, patency of bile conduction. But you also can look at your detoxification function. Less metabolic acidosis, and most importantly, lactate clearance also indicates that your liver is working. If you have a patient with known liver disease, there are two systems how we can grade the liver disease severity. The older system is the Child-Tucker-Pugh classification, here shown in the more yellowish table. And for the presence of encephalopathy, ascites, level of bilirubin, level of albumin, and your coagulation function, you get points, and therefore you get categorized in child A, B, or C category. However, this older system has completely been taken over by the MELD score. The MELD score is a mathematical calculation using creatinine, bilirubin, and the INR to give you a score, not a category, a score for how advanced your liver disease is. So therefore, it allows you, based on the score, to really grade and trend the progression of your disease and to predict survival. So let's talk about this MELD score a little bit further. Again, it's bilirubin, it's INR, indicator of liver synthesis, and then creatinine, indicating to you the closeness of liver and kidney when it comes to function. And based on this calculation, we can grade your liver disease and your progression, and it's a very good predictor of your 3 months mortality. So looking at if you have a MELD score of less than 10, your expected 2 months mortality would be less than 2%. If your MELD score is between 20 and 30, your 3 months, predicted 3 months mortality is more around 20%. And if your MELD score is above 40, you have a more than 70% to die within the next 3 months. So therefore, it has been used by UNOS to locate and allocate organs for patients waiting for liver transplant. We usually would like to see a MELD score of above 14, around 14 or higher, to proceed with liver transplant, since then the advantage of and risk of liver transplant is more on the benefit sides than the risk undergoing this high-risk procedure. So speaking of liver transplant, the only keyword I'm reviewing here is NEOHEPATIC and REPERFUSION. However, for those who are listening and have not done liver transplants yet, liver transplant is a procedure which goes in 3 stages. Stage 1, after doing the incision and exposing the liver, is called the pre-anhepatic stage. At this point, you just basically dissect down to the blood vessels, bringing blood to the liver and making sure that you have access and you can isolate the liver blood supply. So after the pre-anhepatic stage is completed, you cross-clamp the blood vessels to the liver, the portal vein, the hepatic artery, and the IVC, the so-called anhepatic stage. At that point, you have removed the liver from all blood supply, and you can cut it out, take that liver out, and put in the new one in the anhepatic stage. Then you put the new organ in there and start connecting it to those blood vessels. And then you open up the blood supply and you start the neohepatic phase. And when you open up all those, the blood supply, portal vein, IVC, and hepatic artery, it's called reperfusion. And it's a very exciting moment in this procedure, in the liver transplant, because the opening of the portal vein, that's usually the first one you open, after the IVC, allows systemic blood to enter the donor liver. And then what means is that you get acidotic, cold, and hyperkalemic blood into the systemic circulation. We already discussed previously the distance from the hepatic vein to the right heart is very short, probably within 2 inches. So therefore, all that blood from that donor organ enters the heart very quickly. So you may see a lot of arrhythmias in the ballpark of from bradycardia, ventricular fibrillation to cardiac arrest. All is possible. All that acidosis, cold, and mediator-rich blood can cause significant hypotension, decreasing cardiac contractility, reducing your systemic vascular resistance, and also there may be still particular matter in there. It also can cause pulmonary embolism. Most of the times, you do see an increase in pulmonary vascular resistance due to the microembolization coming from this donated organ. Really depends on the preservation, how well it was perfused during the donation process. But since now also the IVC is reopened and you get a lot of blood back from your lower body half, you also see a hypervolemic situation and also transient increase in pulmonary blood flow. That's the immediate 5 to 10 minutes of your neohepatic stage, the reperfusion stage. A lot of those abnormalities I discussed are short lasting and controllable, but definitely requires your full attention. After that, after reperfusion, you most of the times have your hands full with still stabilizing hemodynamics, but you also need to pay attention to your coagulation cascade because your patient previously hadn't had a liver, so therefore was recoagulopathic. And now the new liver is starting to making coagulation products pretty early on. You have to keep an eye on it, how fast it is progressing, how quickly that new liver likes the new environment and start producing coagulation factors. We monitor TAG pretty closely in this stage. My previous podcast, I think, explained the thromboelastogram more details, so I'm not going to go into that, but this would be a typical TAG you may see in the neohepatic stage. And you monitor for fibrinolysis, as displayed here in this little graph, little picture, the fishtail, where you see that the reperfusion injury, the mediators released by this cold acidotic organ does activate your coagulation cascade and causing a DIC type of picture. And here you just counteract by giving products containing fibrinogens or cryoprecipitates, and platelets most of the times need to be transfused in that stage to stabilize the coagulation situation. Keep in mind you just made major vascular connections between IVC, portal vein, and hepatic artery, so you surely don't want this to bleed significantly. Maintain normothermia, also very important for coagulation functions and for hemodynamics, that you try to get this patient back to normal core temperature as much as possible. So moving away from liver transplant, more broadening up towards post-operative liver function assessment. What do I do if post-operatively my patient, any type of surgery, post-operative patient, has an elevation in your bilirubin level? Broadening up your differential diagnosis, you may think about like, what prehepatic causes could be related to hyperbilirubinemia. Then assess like if your liver function may be abnormal, or if there's an indication for post hepatic causes, meaning in obstructive type pictures. And so your differential diagnosis really goes down to what type of bilirubin is elevated. You need to know if it's the unconjugated, meaning pre-liver, your indirect bilirubin, or if it's the conjugated form, meaning your liver has already gluconized your bilirubin, and so therefore it's direct bilirubin which may be elevated. So early on in evidential diagnosis, you need to get that separation from total bilirubin, if it's direct or indirect. If it's the indirect bilirubin, then it's most likely coming pre-hepatic, or if it comes then to the liver uptake. So hemolysis may be an increase in your unconjugated bilirubin, or the liver uptake is impaired, as with the Gilbert syndrome or the Crigler-Najjar syndrome, affecting how easy the liver has access and can process your bilirubin. If it's a conjugated form, then it may be an obstruction of your biliary system, as it would be with a gallstone, gallbladder disease, or pancreas tumor, pancreas-related obstruction. It also may be intrahepatic, so here very common hepatitis due to virus, hepatitis A, B, C, alcohol-related or non-alcoholic related, as it would be NASH, your fat liver turning into cirrhosis. Also due to sepsis, TPN, cancer, drug toxins, as a picture of hepatocellular injury. New keyword, the carcinoid syndrome. So what is carcinoid? Carcinoid is a tumor, a slow-growing mass, most of the time located in the abdomen, but any kind of foregut structure can be location of a carcinoid tumor. So abdomen, most of the times, or thorax, lung, or bronchial tree also are cells which can develop this type of malignancy. It's capable of growing metastases, but the hallmark of this carcinoid tumor is the secretion of bioactive substances. Most of the times serotonin, histamine, bradykinin, but also can be a catecholamine secreting portion. The way how a carcinoid manifests is by flushing, GI hypermotility, diarrhea, abdominal pain. These are usually the hallmarks of your symptoms. And the severity of your symptoms is related to how well your liver clears the production of those bioactive substances. They are produced in the GI system because most of the times that's where your tumor is located, but then the portal vein drains all that bioactive substance, and so therefore the liver metabolizes. And as the tumor grows more and more, you get more and more symptoms because the liver capacity to clear those substances is limited. So symptoms progress, and so therefore then right heart disease, bronchospasms, and skin coloration then are more advanced signs of that disease. The diagnosis of carcinoid is made by measuring the synthesis and then metabolism of serotonin, since serotonin is most common bioactive substance released by this tumor. So here in this little graph, you see the metabolism products of serotonin. So we measure the 5-HT and the 5-HIAA in the urine. And if this is elevated, you have made your diagnosis of patients having a carcinoid. The symptoms, as we already said earlier, flushing, bronchoconstriction, diarrhea, abdominal pain, these are the hallmarks. Blood pressure can be hypo or hypertension, depending a little bit on your response of the adrenal system towards those bioactive active substance reduced. Intraoperatively, we're more worried about the hypotension, but surely also hypertension with tumor manipulation has been described. The carcinoid heart disease, as shown in this little picture, right heart disease, and it affects the valvular system with those plaques, but then also like atrium and ventricle as a more fibrous tissue modification. Tricuspid regurgitation, pulmonary insufficiency are the most, not common, but most seen valvular abnormalities, and then the effect on the cardiac conduction system by developing arrhythmias. This has been most commonly described with the carcinoid heart disease. Left heart involvement is a more form of later progression and more common if there's a significant pulmonary involvement of carcinoid. Next keyword, new keyword, the Enhanced Recovery Protocols, also termed the ERAS, the Enhanced Recovery After Surgery Protocol. This is a cascade of different elements coming together in a multimodal perioperative pathways with the goal to achieve an early recovery and discharge for our patients after surgery. This graph here is from a JAMA article describing all those different components, and it's not only us, it's not anesthesia, it's really a multi-player, team-based approach to give our patients the best possible outcome. So pre-admission, our surgical colleagues focus on optimization, and so do we. Medical optimization of all existing comorbidities, smoking cessation and alcohol intake reduction, optimized nutrition, that's what we focus on. Then pre-operatively, for us, we still abide our NPO guidelines, but we want our patient better hydrated. And we also include a pre-operative carbohydrate load. We focus on PONV prophylaxis. Intraoperatively, our surgeon focuses on minimal invasive techniques. We focus on a multimodal analgesia by using regional anesthesia, reducing our reliance on opiates for perioperative analgesia. We use a conscientious hydration protocol, balanced fluids. I think a good term to say if you don't want them under or over resuscitated. And we maintain a normothermic patient. The biggest impact probably is on our post-operative approach to a patient, because our surgeon also here focuses on moving a patient forward. Remove drains and anything which holds a patient back, keeps them in bed. We continue our concentration of multimodal opiate-sparing analgesia. Everything is focused on get our patient out of bed, let them eat and drink as early as possible as it is tolerated, so our patient can return to normal function as early as possible. These are the hallmarks of our enhanced recovery after surgery protocols. Next keyword, our TUMESCENT liposuction technique. We rarely use here at our institution, however, private practice probably much more commonly seen. What it is, you use a large volume of a very dilute local anesthetic solution, lidocaine with epinephrine, and you infiltrate that into fat tissue so you can then remove that fat tissue. And when I say like large volume and very dilute, we're talking about like a 1 gram of lidocaine with 1 milligram of epinephrine in 1 liter of normal saline. According to the technique guidelines, the maximum recommended dose is 40 to 55 milligrams per kilo body weight. Now this is a lot higher than what we usually see as a recommendation for lidocaine toxicity and lidocaine toxic levels. Well, that's because you infiltrate that in fat tissue with a vasoconstrictor, so therefore you decrease the uptake of lidocaine, so therefore you get away with a much higher limit. This technique provides local anesthesia and it provides vasoconstriction, so therefore you reduce blood loss and you delay absorption of your lidocaine. To give you some idea of what to expect, your anesthesia is up to 10 hours and your analgesia is more than 24 hours. But yeah, you have a lot of assumptions here that, you delay the absorption of this pretty high amount of lidocaine. So the complications are related to what if this doesn't work? So surely you have given a high dose of lidocaine, this can be absorbed faster, so therefore you are at risk for lidocaine toxicity. And the peak of this absorption may not occur until 12 to 14 hours post-injection. At this point, your patient may already be discharged, and so therefore not really being aware of that they are developing local anesthetic toxicity. A lot of this depends on your hepatic ability to metabolize. Your P450 cytochrome responsible for that, and surely also other medication, acetaminophen, codeine, cyclosporines, rely on this enzyme system. And by giving a pretty high volume of normal saline, you also hope that your circulatory system can manage that, otherwise you're at risk for pulmonary edema. Last not least keyword in this podcast is physiological changes during laparoscopy. Laparoscopy relies on inflating your abdominal cavity or tissue with air or CO2. The reason to use CO2 is because it's non-flammable, so therefore allows you also use of electrocautery because it doesn't contain oxygen. But by using CO2, you're also using CO2 for you're inflating that and needs to be absorbed, so therefore you are developing a hypercapnic situation, which stimulates your sympathetic tonus. A lot of physiological changes you see during laparoscopy are related to patient position, reverse Trendelenburg versus Trendelenburg, head up, head down. Surely all the other changes are more or less affected by that. So let's first focus on your cardiovascular system and how the increased intra-abdominal pressure affects that. Somewhat a biphasic response. In the beginning, you see an increase in arterial blood pressure. Here, even measured with different methods, your MAP goes up, related to an increase in systemic vascular resistance, which most likely is caused by endocrine factors, vasopressin, renin, and norepi. Your heart rate, not much affected by it. You worry more about the vagal response, the bradycardia to asystole, which also has been described during laparoscopy. If you look at advanced hemodynamic monitoring, your PA catheter in central venous catheter, your wedge pressure in CVP are increased secondary to increase in intra-abdominal pressure. However, your cardiac index, your cardiac output, actually is decreased, pointing out to you that your fitting pressures, left heart, right heart fitting pressures, do not correlate with your cardiac function. They do not indicate what your cardiac output is doing. After time of adjustment, the increased intra-abdominal pressure compromises, and also the level of intra-abdominal pressure compromises your venous return, so therefore can decrease your cardiac preload, and so therefore also compromise your cardiac output, then cause hypotension. Also aggravated by body position, probably more seen in head up position than in steep Trendelenburg. Other changes, physiological changes during laparoscopy. We already touched on your neurohormonal response, elevated ADH, antidiuretic hormone, renin, aldosterone levels have been reported. Your plasma norepinephrine and epinephrine levels also are elevated due to increased intra-abdominal pressure. However, secondary to your increased blood pressures, the renal circulation actually is decreased. And it's true in your cortex and medulla blood flow, so therefore your GFR is reduced during laparoscopy. Significant effect of your laparoscopy on the respiratory system. The gas exchange, we already touched on the CO2 absorption. The CO2 absorption is worse in extraperitoneal inflation than in interperitoneal inflation, in V compensating for the increase in CO2 absorption with increasing mini-volume ventilation. The increase in intra-abdominal pressure does increase your dead space ventilation to the point that your gradient between arterial and end-tidal CO2 is very much variable, and your end-tidal CO2 may not reliably predict your arterial CO2 anymore. So if you have advanced COPD or a patient who is at risk for effects of hypercapnia, you may have to monitor the arterial CO2, end-tidal not sufficient. Pulmonary compliance also is affected by your increased intra-abdominal pressure. Also keep in mind the body position. This is worse in steep Trendelenburg than it is in increased head-up position. But your pulmonary compliance, more the extra thoracic compliance, is affected, and therefore increase your shunt fraction. FRC is reduced in morbid obese patient or patient with already increased intra-abdominal pressure. Your FRC may be reduced to the point of being less than closing capacity, so therefore causing and explaining hypoxemia. I'm sorry for the typo here. All right, well, this concludes my podcast. Good luck with the in-training exam, and please contact me if you have any further questions.